This Circles of Support and Accountability training video is produced in conjunction with the United States Department of Justice and is part of a larger package related to Circles of Support and Accountability project development in the United States. I recognize that this video may have some use for people external to that process, and I should note that there is a PowerPoint that goes along with this that you can get either as part of that package on the US DOJ website, or you can find it under the Circles of Support and Accountability tab on my personal website, which is www.robinjwilson.com. The topic of this particular video is working with persons with special needs. Many of our core members in Circles have complex presentations that include difficulties or issues in a variety of areas that we may refer to as a so-called special need. This can include things like, for instance, mental illness. It can include intellectual or other cognitive limitations that may come from a number of different experiences or accidents or whatever that happen in people's lives. It's my belief that because we tend to get people in Circles who have long-term histories of involvement with the law, and that they often have pretty serious histories of adverse childhood experiences, whether that's abuse and neglect, poor educational opportunities, poor nutrition, broken families, all those sorts of things that increase risk for engagement in inappropriate conduct in later years. Being familiar with these conditions and the effects that they may have on our core members, I think will ultimately help our Circle volunteers to be more effective in the work they do. I want to start off by talking a bit about mental illness. So mental illness is any disease or condition that affects the brain, that influences the way that a person thinks, feels, behaves, or relates to others and his or her surroundings. Certainly, the symptoms can vary from one person to another, and they can be mild or they can be severe, and they may be different depending on what type of mental illness the individual is experiencing. A person with an untreated mental illness is often unable to cope, or sometimes has a lot of difficulties with respect to their daily routines and the demands of life. So being familiar with these sorts of difficulties, if you have a core member who experiences them, will assist you in being a more effective Circle volunteer. The exact cause of many mental illnesses is not known. However, the research is pretty clear that these conditions are typically a combination of factors, some of which may be genetic or biological, physiological sorts of things. There may be psychological elements, and of course we can't discount the possible influence of the environment as well. We know that there's no specific profile of a person who's going to experience a mental illness. We've seen it in persons of any race, any age, any religion, any degree of income, any degree of education. The most highly skilled and best paid people on the planet can become mentally ill. Homeless people can be mentally ill. Black people, white people, Africans, Asians, Australians, Canadians, who knows? Young people, old people, short people, tall people, skinny people, fat people, middle of the road people, doesn't matter. One thing we know for sure, however, is that mental illness is not the result of personal weakness. So it's not a matter of, you're just not a good enough person not to be mentally ill. It's not a character defect. It's not necessarily the result of a poor upbringing, although we know that there are certainly some effects later in life of adverse childhood experiences. We certainly want to pay attention to that, but recovery from a mental illness is not simply a matter of will. It's not about self-discipline. It's about making sure that you attend to the root causes of the experience that you're having, and what I believe to be first and foremost, making sure that you have a good support network. So actually, this is where a circle of support and accountability can be really, really helpful for a person with a mental illness. And we know that people who experience these sorts of conditions, typically have a much better prognosis when they have a strong social support network. Lots of different types of mental illnesses. I'm not going to talk about all of these in depth, but let's just sort of run through them. There's the sort of psychotic disorders like schizophrenia or schizoaffective disorder. Those sorts of things where there's a pronounced loss of touch with reality. Bipolar disorder, also sometimes referred to as a kind of manic depression. We have people who are both way, way high at times and way, way low at others. Major depressive disorder, so people who are sort of chronically depressed to the extent that they may experience some symptoms of psychosis, complete social withdrawal. Obsessive compulsive disorder, people who engage in sort of obsessive behaviors like hand washing or sort of other sorts of things that interfere with their ability to lead a normal life. Anxiety disorders, perhaps more common. This would include, to a certain degree, post-traumatic stress disorder as well. We'll talk a little bit about that later on, because we know that there are a number of our core members who show symptoms of post-traumatic stress. Pervasive developmental disorders. This is going to include things like autism, attention deficit and hyperactivity disorder is sort of commonly diagnosed amongst some people within the forensic domain. And then we'll talk about personality disorders, and these are the sorts of things like antisocial personality disorder with or without psychopathy, borderline personality disorder, narcissistic personality disorder. Those are the ones we'll typically focus on here because they're the ones that are most commonly found within a criminal justice sort of population. Mental illness is treatable. We don't need to lock people away. They don't need to go to insane asylums. That's not to say that there aren't some people who will need to be in those kinds of protective environments for their own safety and perhaps for the safety of others, but there are treatment methods that we can bring to bear that will assist our clients in becoming better. Sometimes this may require some sort of a medication regime. Excuse me. But medication is very rarely the only thing you need to do. Typically, this needs to be accompanied by some sort of counseling or perhaps intensive psychotherapy that attempts to deal with whatever the issue is to try to lessen the reliance on medication, perhaps, or to assist the individual in devising a better life plan that's going to reduce the intensity of some of the symptoms they experience. So there are a number of different ways to get that help. It can be kind of self-help programs, and there are lots of self-help type programs for people with mental illness. But they're going to need assistance largely in other areas too, like finding appropriate housing, trying to ascertain what the effect may be on employability. Sometimes people with a mental illness need to go on a pension of some sort, whether that's Social Security benefits or some sort of a disability pension. Those are all the sorts of things that need to be considered in order to make sure that people with a mental illness are just not sort of left out there hanging, fending for themselves. And of course, that happens from time to time, and we see that within certain segments of the homeless population where mental illness is unchecked and probably creating many of the circumstances that led to the homelessness. Early identification is key. So if we're going to deal with the problem, identifying it early on before the individual starts to experience some of the higher level negative consequences is the best way to deal with this. So we want to identify the problem early on, get the people the treatment they need before they lose all of the compensatory things that might actually in the end be helpful. So if someone starts to experience kind of mental illness symptoms, but has a job, has a family, has some degree of social support, if we were to allow that mental illness to go unchecked, they may lose their job, their behaviors may lead to social difficulties. There's a whole host of different things that are going to get people in trouble that we want to make sure that we don't that we don't allow it to get to that point. Let's talk for a moment about post-traumatic stress. So I mentioned earlier about adverse childhood experiences, and this is a really interesting new area of investigation with respect to people involved with crime. Surely all of us know someone who had not the world's greatest upbringing. Whether it was one of their parents left, or one of their parents was abusive, or where they were quite poor and didn't have adequate nutrition, or didn't have the opportunity to go to school, or had to leave school early because they needed to get a job to help pay for things in the household. We know that people who are involved in crime didn't just wake up one day and say, hey, I think I'll become a criminal. That often there are aspects of their life experience that pointed them in that direction. And we know that adverse childhood experiences, these things that I'm talking about, are much more prevalent in forensic populations than they are in, kind of the regular community. Many of our core members are likely to have experienced abuse or other unpleasant circumstances when they were younger, or perhaps while they were incarcerated. This is part of that complex presentation that I've mentioned in this video and others, in which, again, it's not just a matter of being antisocial, it's not just a matter of being a mean and nasty person, that, many people find themselves involved in crime for a whole host of reasons, some of those involving some of those adverse childhood experiences. But we really do need to consider the whole person, and we need to take a look at where all of those difficulties may be linked to one another or to certain circumstances, and that this can be a component of post-traumatic stress. And for some of our core members, they may actually have a full-blown post-traumatic stress disorder. If that's true, that affects how they interact with others. That affects how they manage themselves. It has a lot to do with impulsivity. It has a lot to do with their coping skills, with their cognitive problem solving. It can, in many ways, add a degree of color to a lot of the sorts of things that you may be engaging in with your core member. So probably important to keep in mind that many of the people, because we tend to deal with in circles a high-risk, high-need population, that many of those people will have a myriad of difficulties that may impact how they function within the circle, and it's good to know about that. Impulse control disorders. So many of our core members will have substance-related disorders, such as alcohol abuse or dependence, amphetamine dependence, cannabis use, cocaine, all those sorts of things. They may also have some impulse control difficulties in other areas, like gambling or excessive spending, kind of kleptomania, which is like sort of shoplifting. People who have money in their pocket and who are able to pay for things, but who engage in shoplifting because it gives them a thrill. And of course, many of the people we have as our core members will have some degree of difficulty with regard to compulsive sexuality, whether that's engagement in things that we deem to be, deemed to be sexually deviant, or things that are repetitive, indicating some degree of sexual preoccupation. These are the sorts of things we're going to need to be thinking about as well. And on that topic, there are the paraphilias. So you may have heard this term before. This is the diagnostic catch-all for the ilias and isms that speak about sexual behavior. So here we have a number of different disorders. In the DSM-5, just actually, I think I have a copy of that right here. This is what it looks like. This is the diagnostic manual that comes from the American Psychiatric Association, and it's used widely by psychologists and social workers and other people who work within the mental health field. And it gives us some descriptions of different disorders, so that if you can tell the apples from the oranges. It's often helpful in being able to then ultimately determine what the course of treatment or case management may be. But if you go to the section with respect to the paraphilias, there are 8 named paraphilias that have their own individual criterion sets. And what a criterion set is essentially the diagnostic criteria. And these will be set out in the DSM-5, just the Diagnostic and Statistical Manual of Mental Disorders. As I said, it's a publication of the American Psychiatric Association. So with respect to the paraphilias, there's voyeuristic disorder. These are people who, kind of compulsively peep in windows, trying to see people undressing or engaging in, sexual conduct. Exhibitionistic disorder. These are people who expose themselves, usually to a stranger in a public place, like on a bus or in a park or in an elevator, something like that. There is frauderistic disorder, which speaks about people who, touch people intimately without their permission or rub their genitalia against them. This is, commonly experienced in, crowded spaces where there's some degree of physical contact that people expect just as a natural consequence. So if you're on a bus and the bus jostles and you bump into the person next door to you, that's not an uncommon experience. Some of those folks may actually be bumping into you on purpose because they can have the sensation of rubbing their genital area against your backside or whatever the case may be. Fetishistic disorder speaks to people who are turned on or who are sexually fixated on inanimate objects like shoes or nylons or leather. Pedophilic disorder are those people who are strongly sexually interested, sometimes to the extent of an actual preferential interest in prepubescent children. Sexual masochism disorder are people who derive sexual pleasure from having pain inflicted on them. Sexual sadism disorder is the opposite. These are the people who derive sexual pleasure from inflicting pain on others. The last one of the named 8 is transvestic disorder. These are people who derive sexual pleasure from cross-dressing. So they wear the clothing of the opposite gender because it makes them sexually aroused. And I think it's important to draw a distinction between transvestic disorder and transsexualism, or people who have a sexual identity disorder or a kind of gender identity issue. And it's not always a disorder. I shouldn't necessarily cast it that way. But there are some people who are quite troubled, I suppose, and to that extent there may be a disorder. But the difference between transvestism and transsexualism is that the transvestite engages in that behavior because it makes him sexually aroused. whereas a person who is trans just feels more comfortable dressed in whatever gender they decide is, the one that they'd like to be. So it has nothing to do with how sexually aroused they are. It has to do with how comfortable they feel in their skin. The DSM, and actually, if you work in this field long enough, you'll know that there are many, many, many different paraphilias that are possible, not all of which have an individual criterion set spelled out in the DSM-5. If we want to make these diagnoses, there are two catch-alls that you can use. One is called other specified paraphilic disorder. In this instance, you would use that to denote some sort of a paraphilic interest or preference where there's a name for it and where it's been discussed to a certain degree within the overall scientific literature. So for instance, kind of gerontophilia, be someone who is sexually interested in elderly people. There's a wide variety of different types of these sorts of things that would speak to it. Kind of bestiality, or kind of zoophilia, people who are sexually interested in animals. Urophilia, people are interested in urine. Coprophilia would be for feces. There's a wide variety of different things that people become intensely sexually interested in, and they can fall under this other specified paraphilic disorder. When you have a condition that looks like a paraphilia, you're not entirely sure, it's got some elements of the diagnostic criteria for a paraphilia generally, but there's maybe not a name for it, or maybe this is the first time anybody's really talked about it, that would fall under unspecified paraphilic disorder. And this is, I think, probably reasonably uncommonly used. Personality disorders are where we're going to see a lot of features in our core member presentations. And the most common of these is going to be antisocial personality disorder. And to a certain degree, just becoming involved with the legal system is almost enough to get you to a certain point where people are going to consider whether or not there's some degree of antisocial personality disorder. So there are a large number of personality disorders. We're not going to talk about all of them, but there's antisocial personality disorder, borderline, schizoid, or schizotypal. The schizoid folks are the loners, the guys who sort of pathologically want to be left alone. Schizotypal, those folks who are a little bit on there's an oddness about them that's not necessarily schizophrenic, but certainly in the ballpark. There are people who have a paranoid personality disorder. Those are the people who think that everyone's out to get them, or that there's something inherently unique about them that causes other things to not go well for them or to make them the center of attention. There's narcissistic personality disorder. These are the folks who are concerned only about themselves to the extent that they seem almost unable to entertain the idea that their conduct or the way that they manage themselves has impact on others. And you can see how that might dovetail quite nicely at times with antisocial personality disorder. There's histrionic personality disorder. These are people who are, always a little bit on the edge, always, perhaps a little bit on the edge of sort of flying off or not being able to manage things. They tend to be a little hysterical. They tend to overreact to a lot of things. There's borderline personality disorder, and you may find this quite frequently in your core member population. Some people believe that borderline personality disorder for many people has its origins in experience of childhood abuse, and there perhaps could be a lot to do with that. People who are sort of borderline personality disorder are the folks that fly off the handle very quickly. They seem to be really, really clingy at times. They seem to have a real difficulty with respect to how they view themselves in relation to others. We're going to talk a little bit more about the borderline folks in a moment, most specifically because it's a relatively common presentation in the core member population. Then we have avoidant, dependent, and obsessive compulsive personality disorders, and these are, sort of very much along the lines of what their names are. So a person who is avoidant is the person who has a very difficult time being socially engaged with others. A dependent person also has difficulties with being socially engaged, but in the other way. So whereas the avoidant person is always trying to keep himself apart from others, the dependent person pathologically clings onto people. And I'm sure you've all heard the term stage 5 clinger. A stage 5 clinger probably has a dependent personality disorder. The obsessive compulsive folks, as we talked about before, obsessive compulsive disorder would have some overflow into obsessive compulsive personality disorder, where there is a tendency to engage in kind of repetitive behaviors or be obsessed with certain things in life. Antisocial personality disorder is going to be the most commonly experienced personality disorder within your core member population, and most of them will have at some point probably been diagnosed with this, or somebody has queried it. I should note that there is an extremely virulent sort of variant of this known as psychopathy, or the psychopathic personality disorder, sometimes also referred to as the sociopathic personality disorder. And these are the folks who are very, very antisocial to the extent of being quite violent, of being very instrumental in their use of others. It's almost that sort of idea, you have something I want, I'm going to take it, and I don't care what happens to you in the process. And that process can be at times violent. So antisocial personality disorder is characterized by a pattern of disregard for and violation of the rights of others. Typically it starts to show itself in mid-adolescence, around 15 years old or so, and there are a number of different elements that we look to make a diagnosis. A refusal or failure to conform to social norms, and this can be in relation to lawful behaviors or repeatedly engaging in the same bad behaviors that have a high likelihood of leading to incarceration. Deceitfulness, repeated lying, that sort of pathological lying, use of aliases, being conning, with respect to others for personal profit or pleasure. Impulsiveness and a failure to plan ahead. So being stuck in the moment perhaps without necessarily considering what the long-term consequences of your actions might be. Irritability and aggressiveness. Typically people who are antisocial find themselves getting in fights with others. Not necessarily always physical, but certainly possible. Reckless disregard for their safety and the safety of others. So an antisocial person would be quite happy to be the sort of guy who, and we've all experienced these sorts of folks who weave in and out of traffic at a high rate of speed during rush hour simply because they want to get where they're going and they don't really care whether or not that causes you to drive into the guardrail or not. There's that consistent irresponsibility in people who are antisocial, which is often characterized by an inability to maintain work or to honor their financial obligations. And I suppose one of the biggest features of antisociality is a lack of remorse or an inability to empathize with people. That sort of idea that I'm going to do what I'm going to do because I want to do it and I don't care what you think. And if somebody gets hurt in the process, well, they should have stayed out of the way, right? That kind of idea. Some core members who have antisocial personality disorder, as I said, might also have been described as being psychopathic in the past. And there's been a lot said about psychopathy in the past, specifically that you can't treat a person with psychopathy or that you can't manage a person who has those sorts of leanings. More recently, I think we've come to an understanding that everybody can get better. It's just a degree of how much better is enough better that it means that we can, sort of loose the restraints to a certain degree. So more recent perspective would be that people who are diagnosed with psychopathy or with very highly entrenched antisociality can get better, but it's a matter of whether or not they can get better enough. So this is the sort of thing I think that you need to be at least some degree of mindful when working in a circle, that it's quite likely that your core member will be antisocial on some level. Borderline personality disorder is defined as a pattern of instability in relationships, poor self-image, and marked impulsiveness beginning generally late adolescence, early adulthood. And the sorts of things that we typically see in people with a borderline personality disorder are frantic efforts to avoid real or imagined abandonment. And this may be where some of that sort of childhood abuse idea comes from. A pattern of unstable and intense personal relationships characterized by alternating between extremes of idealization and devaluation. So it's the best relationship I've ever had, it's the worst relationship I've ever had, almost cycling back and forth at a relatively high rate of speed. Identity disturbance. Many people who are borderline in their personality structure have a persistent belief that there's something wrong with the way they look or with their sense of self. They tend to very much devalue themselves. You may have people who are engaging in sort of cutting behavior. It's not uncommon for people who have a borderline personality disorder to engage in a lot of sort of body art, whether that's piercings or tattoos or alterations in some way or another. And this is because they have an intensely unpleasant view of themselves, and they're trying in some way or another to either alter that or to cover it up. People who have borderline personality disorder tend to be quite impulsive as well, and these sort of impulse control difficulties are often quite self-damaging. So it may be things like spending or engaging in kind of compulsive sexuality, substance abuse, reckless driving, binge eating, those sorts of things are part and parcel of the borderline personality. Recurrent suicidal behavior, gestures or threats or self-mutilating behavior. So I spoke a little bit before about cutting, and if you were to check the arms of a person with borderline personality disorder, it would not be uncommon for there to be multiple scars, either on their forearms or on their thighs, of times when they've engaged in cutting behavior as a means to reduce stress or to alter their physical appearance because they're sort of chronically unhappy with who they are. Irritability and anxiety, which can last for a few hours. And one of the things about borderlines is that it's often been said that they can go from 0 to 60 in a heartbeat. Sometimes it's just something you say that sets them off. They often have chronic feelings of emptiness, and they will fall into despair at times. And it's not uncommon for people who have borderline personality disorder to also have other sorts of symptoms like major depression or sort of bipolar disorder, where they've got sort of mood swings that are quite huge as well. One of the hallmarks of the borderline personality is an inappropriate, intense anger response or a difficulty controlling their anger. They're the sort of people who fly off the handle and do it big time. There's also often a lot of stress-related paranoia, that when things aren't going their way, they tend to see the world as putting this all on them, that there's some sort of world conspiracy make their lives difficult. As I said before, there's a relatively strong belief among some people within the mental health field that borderline personality disorder is a response to developmental trauma, most often with respect to having been a victim of sexual abuse as a child. There's been lots written about this. And as I've mentioned at other times, this experience of adverse childhood experiences is something that we really need to keep in mind within our core member population, given that we're working with mostly high-risk, high-need individuals, and that it's not uncommon for those folks to have come from some pretty troubled backgrounds. So experience of borderline personality disorder will not be uncommon for long-term volunteers in a CoSA project. The other personality disorder I want to spend a couple of minutes on is narcissistic personality disorder. And this is also something that may be relatively commonly observed within the core member population. And it may be that the core member has some facets of each of these ones that I've been sort of focusing on: the antisocial personality disorder, borderline personality disorder, and the narcissistic personality disorder. In narcissistic personality disorder, there's a great need for admiration along with a lack of empathy. So they want you to think that they're the bee's knees, but they really have little care or concern for others beyond simply what you might be able to provide them, by way of sort of positive affectations and whatever else. So some of the things we look for here: a grandiose sense of self-importance, to the extent that that person may exaggerate their achievements and talents. I'm the best at this, nobody's ever done this better than me. And there's an expectation that they be recognized as superior, as having certain special talents without necessarily having anything to back that up. People who are narcissistic are typically preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. They believe they're special, that they're unique, and that they can only be understood by, or that they should only be associating with other special or high-status people. People who are narcissistic require excessive admiration. They have a sense of entitlement, such as unreasonable expectations of especially favorable treatment. This is the sort of guy who comes into the restaurant and wants the best table simply because he wants it and believes that he deserves it, without necessarily understanding that that table's probably been reserved for weeks. But they expect you to just automatically do what they ask. People who are narcissistic tend to be interpersonally exploitive. They take advantage of others to meet their own ends, often in a way that leaves the other person either hurt or sort of reeling, trying to understand just what happened. And in this regard, the person who's narcissistic tends to lack empathy. And they don't really recognize whether it's on purpose or whether it's just a way of being. They don't recognize or identify with the needs and feelings of others because they're more focused on themselves. At the same time, they may be envious of others or believe that others are envious of them. Typically, people who are narcissistic are arrogant, haughty, both in their behaviors and in their attitudes. Okay, let's switch gears and talk about other special needs. So I want now to talk about intellectual disability and other cognitive limitations. And for the purposes of this video, we're going to include anyone who experiences significant barriers to treatment or risk management success as a consequence of some sort of a neurodevelopmental disorder or other brain-based difficulties, such as effects of a head injury or some sort of disease process that's causing some sort of difficulty in the brain. And it will also include here those people who experience a degree of cognitive decline for other reasons. Many of our core members will experience difficulties in adaptive functioning, which means that they'll have difficulty coping with common life demands, how to meet the sort of basic needs of being someone living in the community. So it's not uncommon for our core members, just simply as a consequence of having been incarcerated for such a long period of time, to experience difficulties in finding housing, with knowing how to open a bank account, how to use a computer, how to do a wide variety of different things that we kind of take for granted, but because they've been incarcerated, they don't necessarily have that same degree of experience. So they're going to experience difficulties with respect to self-care, home living, engagement with others on a social or sort of interpersonal level, use of various resources within the community. They may not have very much self-direction in that they don't know how to manage themselves broadly. Functional academics, many people who are core members have had problems in school and may not have the degree of skill necessary to enter the workforce or to do anything meaningful. We know that some of our core members will also have difficulties with respect to leisure and deciding what to do in their off time, and that sometimes many of the difficulties that they're having bleed over into aspects of health and safety. When we talk about the neurodevelopmental disorders, here we're talking about intellectual disability, or what's known as intellectual development disorder. This is the term for what we formerly used to call mental retardation. There are people who have various communication disorders. There's autism spectrum disorder, and certainly we've talked a lot more recently about autism and Asperger's, which would be a high-functioning autism. Attention deficit hyperactivity disorder, neurodevelopmental motor disorders, so these would be tics or other sorts of things, spasms that that people experience, and then there are specific learning disorders, and these can be things like aphasia or don't remember off the top of my head at the moment, but where people transpose letters, those sorts of things. There are a number of different learning disorders anyway that people experience that can impact their daily living. We also talk about brain-based limitations, and here we're talking about brain injuries. So if someone was in a car accident and part of their brain was damaged, that could be part of it here. If they got hit with a baseball bat in a fight or something or other, that could have an effect on them. We're also going to include here fetal alcohol syndrome or fetal alcohol effect, and alcohol-related neurodevelopmental disorder, which is related to these as well. In terms of things like cognitive decline, here we would include dementia, Parkinson's disease, Alzheimer's disorder, all those sorts of things that that affect brain function, sometimes as a consequence of aging, but not necessarily always. And we've certainly seen some young people who have gotten some of these conditions, especially Parkinson's, where it's been ultimately quite debilitating for them. And this is a degenerative brain disease that will ultimately kill the individual, but that along the way they'll lose some degree of their cognitive functioning. So let's talk for a moment about fetal alcohol spectrum disorder, because I think this may be a relatively common thing within our core member populations. So we know that, and I've been harping on this, but I think it's really important to remember the effect of those adverse childhood experiences. And some of that may be that our core members may be the children of a mother who was a drinker when she was pregnant. And this is the only cause for fetal alcohol spectrum disorder. You can't get it from your mother being hit in the stomach while you were in the womb or anything like that. This is directly a result of alcohol use while pregnant. This is typically expressed in difficulties with respect to the central nervous system. It can affect growth, and it also tends to have what we call dysmorphic facial features. So people who have fetal alcohol spectrum disorder tend to have their eyes set a little further apart. The nose tends to be kind of flat, and if you just sort of feel under your nose, those two little ridges that are there, they typically don't have those. So it's kind of flat across the top of their lip. Not everybody who has a fetal alcohol difficulty will have those dysmorphic facial features, but those people who have the full-blown disorder, those are typically the sorts of things you might see. You can certainly Google it and have a look. There are some pictures of children on the internet that would sort of demonstrate those dysmorphic facial features. So in fetal alcohol spectrum disorder, there's a range of different things. So the first part would be fetal alcohol syndrome, and this is the full-blown disorder, and this would be when someone meets all of the diagnostic criteria. Fetal alcohol effect would be when someone meets some of those diagnostic criteria. Now, sometimes it's difficult to ascertain for certain whether or not the mother actually drank while she was pregnant. You know, the easiest thing, I suppose, would be to just ask her, hey, did you use alcohol when you were pregnant? That would be sort of confirming of perhaps why we're seeing some of the fetal alcohol symptoms. But if the mother says, no, I never drank, it's kind of difficult then to make that diagnosis with any certainty. For someone who has all of the diagnostic features, it's probably pretty easy to say, well, you know, she's not probably telling the truth, and you know, we've got the facial features, we've got the stunted growth, we've got the central nervous system difficulties. You know, this is a likely consequence of exposure to alcohol in the womb. For the fetal alcohol effect folks, we're seeing some of the symptoms, and although we can surmise that it's because of exposure to alcohol while in the womb, you know, it's perhaps a little more difficult to make that diagnosis with any certainty. Fetal alcohol effect is now often referred to as alcohol-related neurodevelopmental disorder, or ARND. Let's talk a little bit about cognitive decline for a moment. So, an interesting phenomenon we sometimes encounter in clients who've been incarcerated for a very, very long time is that it's almost like a brain atrophy as a consequence of understimulation. So because prisons are places where inmates or people who are incarcerated don't have a lot of agency, so they don't have a lot of self-determination, the ability to make decisions for themselves. Think about it. Prisons tend to be very, very highly structured, very much rule-based, and there are at times some fairly intense punishments for stepping out of line. So what time you get up, what time you go to bed, what time the lights come on, what time the lights go off, where you eat, with whom you eat, what you eat, how much you eat, what side of a line you're allowed to be on. These are all things that are determined for you, and that you have little ability to influence. In those circumstances, people sometimes forget how to problem solve, or they forget how to make decisions for themselves. And I've seen this myself, and certainly some of my colleagues have talked about it as well, where there's almost like there's a kind of brain atrophy or an inability to function normally simply as a consequence of understimulation, or a lack of opportunity to exercise your brain, let's say. So there are some people who appear to us as being quite deficient in terms of being able to manage themselves. That's not necessarily the consequence of a brain injury or any kind of neurodevelopmental disorder or any kind of degenerative process because of Alzheimer's or Parkinson's or whatever, but it's just a matter of didn't use it very much and lost the capacity to do so in a reasonable fashion. Regardless of what the origins are, whether it's an intellectual disability, a brain injury, fetal alcohol, or this kind of brain atrophy, cognitive decline that I'm talking about, core members who have these difficulties will experience significant difficulties leading to problems in a wide variety of life areas, including how well they can communicate with you and others, home living, how able are they to establish a home and to maintain it, how well can they interface with other elements of the community, can they make decisions for themselves, that self-determination, self-direction. Excuse me. Can they learn? Can they go to school and learn? Many of our core members will have been people who were in a special education program or who dropped out of school early, not necessarily because they wanted to, but because the process of being in school was just too fundamentally frustrating for them, and maybe the school didn't adapt very well to the difficulties they were experiencing. And this fits firmly with what we know as the responsivity principle, meaning that we need to take into consideration things like cognitive limitations when we're thinking about how we're engaging with people, because those cognitive limitations are really important and they will affect most things. We know that people with cognitive difficulties experience difficulties with respect to sexuality. Sometimes they will have a great amount of difficulty identifying and maintaining relationships with other people where some degree of sexual intimacy might be possible. We know that self-care can be a big issue, and sometimes people with cognitive limitations forget to do certain things. We call these ADLs, activities of daily living, like getting up, washing, brushing your teeth, taking a shower, wearing clean clothes, all those sorts of things. Social skills and relationships. This is kind of a two-way street. So sometimes people with cognitive limitations don't know how to interact with others, and because they're perceived as different, others don't want to interact with them. So there can be some difficulties in both aspects there. Health and safety certainly can be an issue for people who are profoundly disabled or who have sort of disabilities that interfere with their ability to protect themselves or to keep in mind the risks that are inherent in certain aspects of life. Will certainly require some assistance there. Leisure and work. So what employment opportunities are available to people who have a compromised cognitive sort of processing system, and what sorts of leisure activities are going to be appropriate. So you can see that there's a wide variety of different areas that if you have a core member with an intellectual disability or with some kind of a brain-based kind of cognitive limitation, that you may need to be a bit creative in the circle in kind of addressing many of the sort of typical life experiences and things that we do as normal folks that would be perhaps a little more difficult for someone experiencing some of the problems that we're referring to here. So that's a quick run through some of the special needs information that I think would be helpful for a Circle volunteer to know about. As with most of the videos in this series, in the PowerPoint on the last slide there is a for further reading section that highlights some of the books or articles that may help you to better understand. I'll note again that the PowerPoint is available both as part of the larger package on the US DOJ website, or it can be found on my personal website, which is www.robinjwilson.com. And with that, I'll thank you for your time, and I wish you well in your endeavors.